My name is Neha Mehta-Shah, and I'm an assistant professor of medicine at Washington University in St. Louis. ASCO 2021 brought us multiple updates in lymphoma. Some of the things that I thought were most practice changing were Elevate CLL, abstract 7500, which was a phase 3 study in relapsed refractory CLL comparing acalabrutinib to ibrutinib, where we found that acalabrutinib and ibrutinib were equally effective with similar progression-free and overall survival, but ibrutinib was associated with a higher rate of atrial fibrillation, hypertension, diarrhea, arthralgias, and bleeding, suggesting that acalabrutinib may be better tolerated than ibrutinib in many patients. We also saw from the Captivate study, which was abstract 7501, that fixed duration therapy of ibrutinib and venetoclax-based therapy in previously untreated CLL can lead to a high rate of MRD negativity, suggesting that fixed duration therapies may be on the horizon soon in CLL, and this is actively being studied in other studies. We learned from abstract 7503, which was summarized the results of E1411, a US intergroup study in mantle cell lymphoma, that bendamustine-based therapy with rituximab maintenance leads also to a high rate of MRD negativity, 92%, and confirms that bendamustine rituximab-based therapy is an effective and well-tolerated backbone, and rituximab-based therapy may be associated with improved outcomes. This was also seen in an abstract presented by Dr. Peter Martin, looking at the real-world outcomes of mantle cell lymphoma through the Flatiron Registry. Another study I thought was important to highlight was CALGB 51101, which is abstract 7506, that looked at the use of consolidative transplant versus non-myeloablative chemotherapy consolidation in CNS lymphoma. In this study, it was seen that the rates of complete remission were about 50% with induction therapy with methotrexate, temozolomide, rituximab, and that the outcomes looked somewhat better in those who received an autologous stem cell transplant, but this may have been flavored by patients who were randomized to that arm happening to have a higher rate of chemosensitivity to methotrexate-based therapy. And it's unclear what the difference in outcomes based on consolidation is. And then the last abstract I thought was important to highlight is CALGB 50801, which is a study of PET-adapted therapy in bulky early-stage Hodgkin lymphomas, and demonstrated that the use of ABVD ×2 followed by an interim PET can lead to PET negativity in 78% of patients, and those patients can be effectively treated with further 4 more cycles of ABVD chemotherapy without any radiation, with over 90% of patients remaining progression-free at 3 years. Those who had positive PET at their interim could safely be escalated to BIACOP and involve field radiation, again with over 90% of patients remaining progression-free at 3 years. This suggests that radiation therapy can be safely eliminated in patients who have chemosensitive disease to ABVD, even in the setting of bulky Hodgkin's lymphoma. Thank you.